I'm Dr. Chirag Amin, consultant gynecologist at Ahmedabad. Today, I would like to share a case of a patient who was having early pregnancy and had thalassemia minor. This is a genetic disorder where the hemoglobin generally remains low. So when she came to show us in early pregnancy, we detected thalassemia minor in her case, and her husband was having normal HB electrophoresis. So husband was normal. So we continued with her pregnancy and we explained her that her hemoglobin would remain little bit on lower side. That is because of that genetic condition, thalassemia minor. And as the pregnancy progresses, the baby also drains iron from mother. So sometimes iron stores are depleted in mother. So it is a good protocol to intermittently check that what is the hemoglobin level. Now, in a normal condition, most of the time we find iron deficiency anemia and we treat it accordingly. But thalassemia is a unique situation where there is a genetic disorder. So the hemoglobin is low because of thalassemia, but additionally, there may be iron deficiency, which may add on the anemia, and that could be very dangerous. So we continued giving a specific type of iron therapy, which is a low dose iron, which will not harm and overload the iron to thalassemic patient. And later on, at around 28 weeks of pregnancy, we checked her hemoglobin level because anyways, we have to check for her sugar also at that time for gestational diabetes. And we checked her hemoglobin, and along with it, we also checked serum ferritin and total iron binding capacity. Now, these are the indicator which will tell us whether she has got iron deficiency anemia also along with thalassemia. So two other things which can happen is B12 deficiency and iron deficiency, which we checked by blood reports. And we accidentally found out that her ferritin level was only 10. So she was having iron deficiency also. That means that we have got a storehouse of about 1500 milligram of iron in our body, which is the storage. And the iron metabolism goes on in the body. But when the store is depleted, in that case, the ferritin level will go down. So she already had thalassemia, and add on, she had iron deficiency anemia. So we decided to supplement iron. The best form of iron as on today to be given is intravenous iron therapy, because we can give 1000 milligram of iron in a single sitting. So the patient does not have to come repeatedly for iron therapy. And the most safe molecule, which has a very good track record and has been used in Europe extensively and now available in India, is ferric carboxymaltose, which is a very stable molecule. This molecule has got molecular weight of 150,000 daltons, which is a very stable molecular weight. Higher the molecular weight, the molecule does not disintegrate, and that is why it becomes very safe. So we gave ferric carboxymaltose 1000 milligram to this patient IV, and that therapy gets completed in half an hour, and patient can go home safely. And the chances of reaction are very, very less with ferric carboxymaltose. And still, whenever ferric carboxymaltose or any other iron therapy is given intravenously, we always take a consent. We also do it in a hospital setup, and we have to always have preparations ready for any emergency like anaphylactic reaction or any other reaction. When the patient got the therapy, patient was comfortable, and we could see that her hemoglobin, which has reduced to 7 gram because of thalassemia and additional iron deficiency, has now jumped up after 1 month of therapy of iron. It has gone to 9.5, which is little reasonable. Obviously, it will not go to an absolute normal level because of thalassemia. Recently, some of the papers have come which are also suggesting that you can try with giving erythropoietin, which is a stimulator of bone marrow, and it will be useful in thalassemic patients. But the trials are still not up to a large number, and so it is still not a very acceptable therapy. So we have to keep, for such patients, we have to keep blood transfusion also ready at the time of delivery. So a proper management of thalassemic patient has to be done, and we have to rule out that iron deficiency or B12 deficiency does not occur in this patient. Thank you.